Good, inshallah.
Okay.
We have to do hip bone, number one. Then we have to do femur. Then we have to do patella. Important features before even starting. Let's start with the hip bone first. If I have one hip bone, this is simply a hip bone or a nominate bone. Then if we have two bones together, this is known as hip girdle, not pelvis. Hip girdle or pelvic girdle. And if I put a sacrum and coccyx here again, then it is a bony pelvis. Okay, so hip bone, hip girdle, and a bony pelvis. So try to remember these things. Before we start here, okay, let's see what. Okay, let me describe them quickly, and then if some features are left, we can go to the slides. Okay, so what is the anatomical position?
Anatomical position?
No, anterior.
Yes. Good. My hand has a notch here. When this notch fits with this big notch, keeping the acetabulum on the outer side, lateral side, and this thick ischial bone on towards me and inferior. This is how I hold this bone. For example, if I hold this bone forcefully on the other hand, forcefully, the acetabulum should go out. So acetabulum should go here. Similarly, if I have this bone, so this is right bone, this is left bone. Okay, this is which bone? Okay, now what are the parts? Right or left? Good. So now what are the parts? Generally, you have done most of the pelvic part. So I will go on the outer and mostly outer and the part related to the lower limb. Now it has an ilium, then it has a pubis, and then it has an ischium bone. Okay, so ilium, pubis, and ischium. See the big features, then we can move to the slides. The ilium has a blade, iliac crest. I can feel it, iliac crest. Then I have anterior border, posterior border. Anterior border has anterior superior iliac spine, a small notch, and then anterior inferior iliac spine. Posterior, same. Posterior superior iliac spine, a notch, and a posterior inferior iliac spine. These notches are not named, some without. So then we have an iliac crest. It has two lips, lateral lip, medial lip. For some muscles we will see in the lab, inshallah. Then here we have anatomical position is not vertically like this. It's like, because the pelvis, if you try to see the pelvis, it's not straight. It's like this. Okay, it's like this is how it looks like. But if it is like slightly in front, because I have a curvature of the pelvis as well. So here it is like this. Now medial lip, lateral lip, or inner and outer lip. Then we have an important landmark here, tubercle, iliac tubercle. Okay. Then we have pelvic surface, or all this is pelvic surface. Here this is iliac surface divided into by this medial border into front, iliac surface, sacropelvic surface. So sacropelvic surface have a rough part, iliac tubercle, tuberosity. Then we have auricular, like ear-like shape structure, auricular surface, and then we have pelvic surface. Generally, I'm telling you big features. Okay, so iliac bone. Initially, we have outer lip, inner lip, iliac crest, anterior border, posterior border, and medial border. Anterior superior, anterior inferior iliac spine. Posterior superior, posterior inferior iliac spine. Iliac tubercle, iliac tuberosity, medial border. Gluteal surface. The outer surface is gluteal surface. Three big lines. You can feel sometime on the real bones. So one of them is inferior gluteal line. No, there is no middle, unfortunately. They look like middle, yes. So one is posterior, one is anterior, one is inferior. Okay, so gluteus maximus, medius minimus, in between the lines. Okay, then we have this acetabulum. Acetabulum has a notch here. To bridge the notch, there is a ligament, I don't know what I will see. So here is a ligament. Okay. Then we have a acetabulum, a thick, to make even it more, so that the head of the femur becomes more comfortable inside. Okay. So to remain for the stability of the joint. Then for the acetabulum, then we have obturator foramen. Obturator foramen is basically covered in life process with obturator membrane, giving you some place here to pass for the contents, obturator vessels and nerves, obturator canal. Then we have pubis, then we have ischium. These are the main features. The pubis has a symphysial surface to make a symphysis pubis. Then the pubis has a pubic tubercle. It has two ramus. This is the body of the pubis. It has one ramus here. Ramus is this branch sort of a structure, and here. So pubic ramus, superior, inferior. But here it is continuous with the ramus of the ischium. So ischiopubic ramus. Obturator foramen. Again, very quickly, only parts, then I will go to the slides. Ilium, hip bone has three parts: ilium, pubis, and ischium. Ilium has iliac crest, iliac tubercle, anterior superior iliac spine, notch, anterior inferior iliac spine, anterior, posterior superior, posterior inferior, and a notch. Gluteal surface, iliac surface, sacropelvic surface, iliac tuberosity, auricular surface, pelvic surface. This is all ilium. Then pubis, body of the pubis, ramus of the pubis, superior ramus, inferior ramus. Then ischium bone has here, try to see the things in the sequence: greater sciatic notch, ischial spine, lesser sciatic notch, ischial tuberosity. All this is ischium. Okay, ischial tuberosity, ischiopubic ramus. Good. So this is acetabulum, obturator foramen. Let's see the slides. What I have with you?
Doctor,
Ah.
does the lips applied only on the iliac tubercle?
Yes. No. The whole medial lip, lateral lip. The lateral lip contains tubercle. Okay. Okay. Now hip bone. Okay. I decided here. Hip bone is, the other names are coxa, innominate bone, pelvic bone, coxal bone, large irregular bone made of three parts. You know now. Most of the things you will be knowing now. Ilium, superiorly, pubic, pubis, and ischium. Then we have an acetabulum. Then we have an obturator foramen. So here is ilium. Here is acetabulum. Here is obturator foramen. Here is pubis, and here rough back with the notch is the ischium. Okay. Okay. Side determination and anatomical position you know now. Ilium. Superiorly flat part of the bone. This iliac crest, three borders: anterior, posterior, medial. Then we have three surfaces: gluteal surface.
Pubic surface.
Then we have iliac surface or iliac fossa, and then we have sacropelvic surface, which is composed of iliac tuberosity and a auricular surface and a pelvic surface. Next is iliac crest. Two lips, medial and lateral. I told you here, inner lip or outer lip. Then we have highest point is like, if I keep it like this, in a real anatomical position, this becomes the highest point where I have the tubercle. And the anatomical landmark is here, that if I find this point, I will reach, just keep my hand here on a patient like this, and I will try to land L34, which is the best space to get a CSF specimen. So this is the clinical one of the use. From anterior superior iliac spine to posterior superior, okay, no problem, nothing new. Anterior border, anterior superior iliac spine to the acetabulum. Anterior superior iliac spine, anterior inferior iliac spine, these are the features. Posterior border of ilium, what are the features? Posterior superior iliac spine, posterior inferior iliac spine, and greater sciatic notch here. Greater sciatic notch. Medial border, here is the medial border, dividing into iliac fossa and sacropelvic surface. So this is sacropelvic surface. Here we have sacrum, this is iliac tuberosity, and here we have auricular surface. I will show you in a picture now in a minute. Okay, let's complete the outer surface first. Gluteal surface, the outer one is the gluteal surface. 3 lines.
Anterior, posterior?
Yes, inferior looks like anterior. Okay, like here. So inferior, anterior, and posterior. Posterior to posterior, gluteus maximus. Between this and this, gluteus medius, and here is the minimus, main origins. Of course, we have small other muscles. Dr. Tariq will follow you in the lab later on. Okay, then we have iliac fossa here, and iliacus muscle, of course. Then we have iliac tuberosity, sacropelvic surface, this part, sacropelvic surface. Here we have iliac tuberosity. Then we have auricular surface, looks like an ear. See this? Looks like an auricular surface. Look, Nyasli looks like a small ear. Auricular surface, and then we have a pelvic surface here. This is pelvic surface. These are the features of ilium, probably definition. Yes. Then pubis, I told you many parts before even starting. Anterior inferior part of the hip bone. Anterior 1/5 of the acetabulum, it will contribute. Then anterior boundary of the obturator foramen here. Anterior boundary of the obturator foramen. It has body, it has superior ramus, it has inferior ramus, which is in continuation with the ramus of ischium, so commonly known as ischiopubic ramus. Body of the pubis is flat, superior border here. Superior border. Sometimes we have anterior border, and here inferior border. We are talking of the pubic body of the pubis. Pubic tubercle is very important landmark here in front here. This is the pubic tubercle. If I keep it here, I can even feel the pubic tubercle. Pubic tubercle is a landmark for inguinal ligament. Where is inguinal ligament? Anterior superior iliac spine to the pubic tubercle like this. So this is officially the start of the lower limb, because the blood vessel which is coming from here, internal, external iliac, will now become femoral artery. So similarly, the femoral vein, which is coming a deep vein, it will come back as external iliac vein. Okay. Posterior pelvic surface of okay, it has important here medial surface, where this is also known as symphysial surface, where the two hip bones, they communicate and they make symphysis pubis, which is a secondary cartilaginous joint. Anyone knows what is secondary cartilaginous joint? It means there should be a primary joint.
The most stable.
The most stable, okay. There are basically 3 types of joints. Number 1, fibrous joint, when we have a bone, another bone, and in between is a fibrous tissue. Khalas, this is fibrous joint. Then we have cartilaginous joints. Number 1, primary cartilaginous joint. We have one bone, another bone, and one cartilage. This is primary cartilaginous joint. Then we have a secondary cartilaginous joint. We have a bone, we have another bone. On the bone, we have a hyaline cartilage. And in between, we have a disc or other structure, fibrocartilage. So two cartilages, secondary cartilages. And then we have ball and socket and the third variety. Okay? So fibrous joints, cartilaginous joints, and ball and sockets and other varieties of joints. Or synovial joints, they should be classified as. Now, symphysis pubis is a joint with, here, we have symphysis pubis. So here hyaline cartilage, thin layer, here hyaline cartilage, thin layer, and in between a layer of fibrocartilage. This is what we make as secondary cartilaginous joint. Symphysis pubis is the name of the joint. Then we have superior ramus of pubis. Here, body of the acetabulum. Okay, superior border. It has a superior border. We can, when I can finish, I can demonstrate it to you separately. Here we have superior border. Other name is pecten pubis. We have anterior border. The other name is obturator crest. So superior border, anterior border, and inferior border here, making the obturator foramen. This is about the superior ramus. Inferior ramus is simple. Body of the pubis, from body of pubis to the ramus of the ischium. Ischiopubic ramus is the other name because it communicates with the ramus of the ischium. So ischiopubic ramus. Ischium bone. Here is the ischium bone. After ileum finishes, ischium. So what are the things? You know, ischium is contributing into acetabulum. Ischium is making a tuberosity. This is the body of the ischium. Tuberosity. Then we have ischial spine. Then we have lesser notch, greater sciatic notch, lesser sciatic notch. And then we have one ramus of the ischium which is continuous with the ramus of the pubis. So ischiopubic ramus. Are you with me?
Yes.
Good. Body of ischium. For this, we should remember all this sequence. It is of course thick and massive. Try identification in the sequence. Greater sciatic notch, then ischial spine, then lesser sciatic notch, and then the ischial tuberosity. All of you are now sitting on the ischial tuberosities. Okay, so it is the ischial tuberosity on the medial side which makes us a seated posture. Okay, then ischiopubic ramus, conjoined ramus, nothing special except superior border, inferior border, medial surface, lateral surface, inner or outer surface. Obturator foramen, important structure, important. The importance lies in the difference between male and female. The shape is different. It's a large gap between ileum and ischium, here, obturator foramen. Large and oval in males and roughly triangular in females. See the two pelvises. See here, obturator foramen, obturator foramen. Looks like more oval, looks like more triangular here, more oval-like it. Okay, so this makes one of the differences between the male and female pelvis. Of course, there are other differences like the pubic arch. See the cavity or the pelvic inlet is bigger and smaller in male and female differences. Then it is closed by obturator membrane. Obturator membrane will provide here a small area, obturator canal, for the transfer of, for exit of obturator blood vessels and nerves. Okay, obturator vessel, yes. Okay, then we have acetabulum. Okay, what is acetabulum? It's a deep cup-shaped structure, faces laterally forward, and in anatomical position it looks like this. Acetabular notch. Here we have acetabular notch. It is bridged with transverse acetabular ligament. Transverse acetabular ligament. It's good, deep enough, but still we have to make it more deeper. We have a labrum, like we have shoulder labrum here, glenoidal labrum. Here we have a labrum, which is a thick cartilaginous part, which will make it more deep and to stabilize the head and neck of the femur to make the hip joint. Then it has an articular surface which is C shape, like here, or horseshoe shape, even in the joint cavity, we don't have an articular surface. Okay, it is known as non-articular surface here. Non-articular surface. It is a depression, a fossa here, and this is covered with fat normally. So it is non-articular surface. The articular part is covered with hyaline cartilage, of course, and the capsule, of course, this fat and non-articular part is intracapsular. Understand it?
Yes.
Good. Fibrocartilaginous acetabular rubrum deepens, blah 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 blah. Okay, nothing new. Okay, here is so this is first is the transverse ligament to fill the gap of the notch, acetabular notch. Yeah. Then we have a acetabular labrum, which is a fibrocartilage to fix it all the way. Then we have outer to it, the capsule, of course. And just on the inner lining of the capsule, we have synovial. So this is how the whole joint is stabilized. Plus, the synovial membrane has a connection with one of the bursa of the joint. So here is a communication of the joint with a bursa. What is a bursa? Bursa is a sac-like structure which contains same synovial fluid. It is there to reduce the friction between the muscles and the bones, and it is usually may or may not be communicating with the joint cavity, the synovial cavity. Understand?
Yes.
Good. Okay. Okay. Let's start with the femur, and let me do the same with you for femur. Start with small part and just overview, and then. So this is a vertical bone, strongest bone in the world, I must say, and longest bone. Your height is 3 times of your femur. Okay, this is the medical legal importance. If you find a femur in a grave, and what is the height of the person? So femur height multiplied by 3 is your own height. That's okay. Any femur will give you the height. Okay. Side determination. It has a upper head, lower end, and a shaft. The upper end is again composed of a head, a neck, and a greater trochanter. Here we call tubercle. A bigger than is called trochanter. So here we call it as trochanter. Greater trochanter, lesser trochanter. Anteriorly it is smooth. Anterior trochanter line. Posteriorly we have a thick crest. So posterior intertrochanteric crest. So identify main things: head, neck, greater trochanter, lesser trochanter. Then we have shaft, and then we have the lower end. How to make it right or left bone? Keep the head on the medial side. These are 2 condyles. Medial condyle towards the head, lateral condyle on the lateral side. Intercondylar fossa should be on the back. If you forcefully try to fix this in OSP like this, keeping this like left bone, left bone, left bone, this notch or the fossa should go back. So now it is the right bone. So this is how you identify the side, and anatomical position is vertically, roughly just with a slight angle like this. Okay. So head, neck, greater trochanter, lesser trochanter, intertrochanteric line, intertrochanteric crest, shaft. Trochanteric fossa is also there. Trochanteric fossa. Then we have shaft. Shaft roughly has 3 borders, extreme in the middle. We can see clearly. Otherwise, it's flat here, it's flat more even here. So we have 3 borders in the middle and 4 surfaces up and down, like anterior surface, posterior surface, medial surface, lateral surface. Similarly, anterior surface, posterior or popliteal surface, we call this as, medial surface, and the lateral surface. Good? Then we have 2 condyles. On the condyles we have epicondyle. So lateral condyle, lateral epicondyle. Medial condyle, medial epicondyle, another elevation. Okay. Then in the middle, it has a sharp area, which on the real bone you can see two lips and a structure in between, and then dividing into two this triangular area known as popliteal surface. It looks like the medial condyle is bigger, but the more weight transmission is on the lateral condyle because it is more in line with the bone. It is hanging out like this is more in line with the bone, and especially in anatomical position it becomes even more in line with the bone. So it's smaller in size, but it has more weight to get in. Then we have a patellar surface here for the attachment of patella, sabuna. Then we have intercondylar area, intercondylar line, which will separate it from the popliteal line.
What is the line here?
Between the two, here, this green structure.
The fossa
Transverse line.
The fossa is the depression.
They called what?
Intercondylar fossa or intercondylar notch. Okay. Two important tubercles are here. On the posterior side here, on the crest, we have quadrate tubercle, and here we have an adductor tubercle. Quadratus femoris muscle, adductor magnus muscle will come and insert here. These are some general features with anatomical position. Let us see if I missed anything. I can repeat it. Femur, we have head, neck, greater trochanter, lesser trochanter, intertrochanteric line anteriorly, and posterior intertrochanteric crest. Shaft, borders and surfaces, linea aspera. This middle part, very sharp, is called linea aspera. Linea aspera, yes, on the posterior aspect. Linea aspera. Here, this is the linea aspera. Here, this one. This is the linea aspera. It will divide into two areas, two lines, medial and lateral, and include a triangular popliteal surface. Then two condyles, medial and lateral. Now let's start with some features of the head. The head makes the hip joint. It is having a hyaline cartilage. A special feature of the head is it has a depression here in the center. This is known as fovea. Some books say fovea centralis or fovea, no problem. Depression, this fovea. Ligamentum teres or round ligament of head. The round ligament of head is attached here. If it is attached here, where it will attach to the joint?
Inside the fossa.
I told you a notch. I told you a transverse ligament. So it will go and attach to transverse ligament like this. Okay? And after that will be fat. The importance is this ligament contains a blood vessel, a branch from anterior division of obturator that will supply the head region here. Plus, we have medial and lateral circumflex femoral arteries, and their branches to supply. If unfortunately there is a fracture of the neck of the femur, which is fairly common in old obese ladies, especially with osteoporosis, it's really common. So this is going to land up in a situation known as ischemic necrosis of head of the femur. Ischemic necrosis will take place if there is a fracture and the blood supply is hampered. So this is known as ischemic necrosis of head of the femur. This is one of very important physical issues related to head. Neck, the angle of the neck is important. 125 with a shaft angle. This is shaft, this is here. So angle should be like here. 125 roughly. Then we have the angle is less in females. It means what?
Wider.
The reason is the wider pelvis. Yes. This is 125. Less is like this. So the female neck of the femur is not at this angle, it is lesser. Okay? And that is the reason, because of the bigger pelvis here, so it will make a joint like this. This is regarding the neck, upper and lower border, okay, that you know. Then we have greater trochanter, you know the location now here. Greater trochanter. Anteriorly, this is the anterior aspect. Line, posteriorly crest. Greater quadrangular prominence, upper border apex. Trochanteric fossa is this structure here. This fossa is trochanteric fossa. Trochanter, trochanteric fossa. Like condylar, condylar fossa. Lesser trochanter here. Conical in shape. Intertrochanteric line, intertrochanteric crest, and a quadrate tubercle. Then shaft is cylindrical, narrowest in the middle. Three borders are only obvious in the middle, 1/3, medial border, posterior border, lateral border. On the upper and lower, borders are not very prominent, so we just say them surfaces: anterior surface, posterior surface, medial and lateral. Here again, anterior, medial, lateral, and we call this as popliteal surface. The middle 1/3 is very sharp. The best name is linea aspera. Okay, nothing new. Linea aspera attachments. Muscles you have to remember if this is your objective, I don't know. Lower end. I have explained to you the lower end initially, widely expanded, two condyles. Once again I can repeat. Two condyles, medial condyle towards the neck side, lateral condyle. The medial looks bigger and heavier, but the more weight transmission is on the lateral because it is more in line with the bone. Then lateral condyle is flat laterally, greater part, okay, lateral epicondyle and popliteal groove here. Lateral side, we have a popliteal groove for popliteus muscle to attach here, popliteal groove. As contrast to the other, we have a condyle, we have a medial epicondyle, and on this line joining the condyle, we have a adductor tubercle. Adductor tubercle. Adductor tubercle for adductor magnus, of course. Adductor magnus is the muscle. Okay? So, khalas. Now, intercondylar notch or fossa, intercondylar fossa or notch separates two condyles inferiorly and posteriorly, here and here. So this is the intercondylar notch. Patellar articular surface, here is patellar articular surface. And here is tibial articular surface to articulate with the tibia and articulate with the patella. So one surface for patella, one surface for tibia. Intercondylar line is the line posteriorly which separates it from the posterior surface. Here, intercondylar line. Here is a good thing about patella. Patella is a small bone. Patella is a small bone. It has roughly a triangular shape. Okay, with apex facing downward. Apex facing downward. It has two areas on the back. This is the rough anterior part. It is enclosed in the tendon of a big muscle, quadriceps femoris. We will teach you tomorrow. Going towards the tibial tuberosity. So it is covered fully like. The posterior articular surfaces, one is bigger one. Lateral is the bigger one always. And medial is. The best thing to find how to find patella, is it right or left side? If I just keep it, can you see? If I just keep it, it will always go towards one side. Not like. Okay? The best way is, see the apex, put it in front of you, keep the bone on the desk. If it goes onto the right side, tilts right side, it is the right-sided bone. If it is tilting on the other side, it is the left-sided bone. Now see this one, for example. I
Right
make the
side.
apex right-sided bone. Another one,
This is left.
apex
Left.
should be away.
Right.
Apex.
Left.
This is the trick. Understand now?
Yes.
Happy? So we can demonstrate it later on as well if needed. Okay. So this is the method how to find right or left. The life is easy now, inshallah.
Inshallah.
Patella is the sesamoid bone, largest one in the body, in the tendon of quadriceps femoris muscle, in front of the lower end of the femur, and apex down left surface skull. Fracture of patella is important. Okay, sometimes we can have a shatter fracture. So what we do wiring of the fracture like this. But this classification is not with me. No worries.
Doctor.
Then, just 1 minute. Then we have neck fractures of the femur, shaft fractures, and ischemic necrosis of the femur. You should never forget before till Yomal. Yeah. So this is what we do it after. Yes, what happened?
We don't have patella or texture. Practical.
Okay, it's a gift from my side. It's a gift from my side, extra gift. So here are some possible fractures, which are again not your objectives, but this I must show you. This is a nice weekend when you are going out and sitting in the car like this, and it is so dangerous. If there is an accident, it happens like this. See this one. It's so bad. Even the look is so painful. So forget all the objectives. Please don't sit in the car like this. Okay. And then I have some self-study slides. If you want to read about more, some structures, I have given them labels and everything will be. Thank you.
Thank you.
Now what we will do.